Welcome to tonight's webinar, Symptom Management Sensory Components. My name is Krista Siff, Programs Manager for CanDo MS, and I will be your moderator this evening. CanDo MS delivers health and wellness education programs to help families with MS thrive. Please visit the CanDo MS website, cando-ms.org, to learn about more CanDo MS programs. The mission of the National MS Society is to help people affected by MS live their best lives as they stop MS in its tracks, restore what has been lost, and end MS forever. You can explore other society programs, services, resources, and connection opportunities at nationalmssociety.org. I'd like to introduce you to Dr. Randall Shapiro. Randy has an extensive background in MS and is the self-described, quote, old guy in MS. He has done it all. He founded the first private practice comprehensive MS center in the US in 1977. He was elected the first president of the Consortium of MS Centers, an organization that he helped found. He helped develop the Hugo Center, which is now, of course, CanDo MS. He served over 40 years on national and state boards of the National MS Society. Randy has lectured and written extensively on all topics associated with MS management nationally and internationally. He retired from private practice in 2009, devoting more time to teaching, consulting on topics related to MS. Welcome, Randy. We're lucky to have you here tonight with us.
Thanks, Krista.
And our other speaker this evening is Kathy San Martino. Kathy works at Casa Colina Center for Healthcare in Pomona, California, in their outpatient center as a neurological supervisor and clinical coordinator. Kathy's workdays are divided between seeing patients in the wheelchair and seating clinic, lymphedema program, as well as one-on-one therapy sessions. She is a consultant for Casa Colina's MS and Movement Disorder Clinic. She has implemented wellness programs for the National MS Society and, of course, is a CanDo MS consultant. Welcome, Kathy.
Thank you.
So now I'd like to go ahead and hand the presentation over to Randy to get us going for the evening.
Well, thanks, Krista. And let me welcome everybody in the United States and Canada, and from what I understand, around the world as well. I'm talking to you from Phoenix, Arizona, where the temperature here is 106 degrees Fahrenheit. For those of you in Canada, it's 41 degrees Celsius. It's hot. It's hot. And the topic we are talking about tonight is pretty hot as well. We have some learning objectives that we want to cover. We want to talk about the ways that sensory changes in MS can affect function, how sensory changes can impact activities of daily living, and we ought to talk about treatment and management strategies to compensate for sensory loss and who to see for treatment of those. We could go to the next slide then, Krista, please. So Kathy and I sort of wrapped our brains a little bit, and we came up with a dozen sensory symptoms that we see relatively frequently, some more than others in multiple sclerosis. I always make the comment when I talk about sensory symptoms that there are symptoms in MS that portend a bad prognosis. Symptoms like ataxia, spasticity, weakness, cognitive problems. But then there are symptoms that don't portend a bad prognosis, and my experience is that sensory symptoms are among those for the most part. And so while these are very bothersome symptoms, and some people focus on them and they become important, extremely important to that individual, they don't usually mean doom and gloom. So we came up with a dozen, and these include visual changes, numbness, tingling, crawly sensations, and cold feet, the MS hug that I've heard so much about over the years, dizziness, lightheadedness, vertigo, laryngitis, trigeminal neuralgia, neuropathic pain, sensory changes that affect balance and coordination, spasms in the arms and legs that are painful in nature, hearing loss, dyspareunia, which is painful intercourse, and dysuria. I might make a comment that because we're talking about so many symptoms doesn't mean that everybody gets these symptoms. They just like in multiple sclerosis, they come and they go, and they're multiple, and some people get them and some people don't get them. Next slide, please. So I'm going to give you some big terms, and I recognize that these are big terms. So before I start talking about big terms and explaining them, I'd like to explain the difference between a sign and a symptom, because we're mixing these, and we did this on purpose a little bit just to confuse you and also to keep your interest. But a symptom is something you feel. I don't necessarily see it, you feel. But a sign is something I see. I can see on examination. So in some circumstances, we'll be talking about signs where I see them, that those signs may give you some symptoms which you feel. So we're going to talk about an optic neuritis and a retrobulbar neuritis. We're going to talk about that. Those are signs. You don't see an optic neuritis. You don't feel an optic neuritis. You feel the symptom, which is decreased vision, and we're going to talk about that. Double vision, on the other hand, is a symptom. It's not a sign. We see the eyes moving in an abnormal way. That's the sign. Diplopia or double vision is a symptom. And then we're going to talk a little bit about an internuclear ophthalmoplegia. And that's the name that I want you to take to your neurologist just to dazzle or her. Just go in and say, tell me, do I have an internuclear ophthalmoplegia? And they will wonder where you came from, because that is a sign. But it's an important sign in multiple sclerosis. It's not a symptom. So we're going to talk about that as well. Okay, 80% of the population have vision problems. Sometimes that's decreased vision, blurred vision, and sometimes very occasionally, rarely, we get a loss of vision. But it's very common, and it often comes back. And we're going to talk more about why and how in a moment. But these can fluctuate. These symptoms, all of these symptoms that we're talking about, not just the vision problems, but all of the sensory symptoms can fluctuate with fatigue and temperature increases, stress, and infections. I'm going to spend a moment about temperature increases for a moment, because it has a fancy term that I feel very warmly about called Uthoff's phenomenon. That's a bit of a pun, temperature increases, that I feel warmly about. But Professor Wilhelm Uthoff was a neurologist at the University of Marburg, and some 20 years ago or so, I got to lecture from his podium in Marburg, Germany, and I was very thrilled about that. He's a different generation, long since have passed away, but he described what happens when a nerve gets heated up and it conducts too quickly and it blocks. And when it blocks, it stops conducting. So that's when a demyelinated nerve that we see in multiple sclerosis stops conducting. The electrical impulse stops flowing because it has blocked because of the temperature change that has occurred. So we see that very frequently with visual problems, where somebody will be exercising, their core body temperature goes up, and they get visual blurring. We call that an Uthoff phenomena. It happens with people who get fever from infections. And sometimes it happens when people are stressed as well. So we have to deal with fatigue, temperature increases, stress, and infections with these sensory symptoms. Next slide, please. So let's talk a little bit about optic and retrobulbar neuritis. You may not realize that the eye is actually an outpocketing of the brain. When we look in the eye with our ophthalmoscope and look into your eyes, we actually see your brain. And we can make some terrific diagnoses by looking in the eye with that ophthalmoscope. We can diagnose diabetes, we can diagnose high blood pressure, we can diagnose multiple sclerosis, we can diagnose a lot of different diseases by looking in the eye, because that optic nerve sits there and we can see it. Now, the optic nerve is very, very sensitive. It's one of the most myelinated nerves in the whole central nervous system. And so when we lose a little myelin here or there in that optic nerve, it really shows itself to the individual very rapidly. And they lose vision, they get blurred vision, and they'll have a pain often in the eye when that occurs, when that inflammation occurs. We see, by looking in the eye, we can see that inflammation. We see that optic nerve look blurry to us when we're looking in, and it's looking blurry to you when you're looking out. But sometimes we look in that eye and you can't see out of the eye, and we look in the eye and it looks perfectly fine to us. And that's because the inflammation is behind the eyeball in the optic nerve. So we have the optic cup and the optic nerve, and when that optic nerve gets it and we can't see it, we call that a retrobulbar neuritis, behind the bulb, behind the eyeball neuritis. So when we see that, we can make the diagnosis usually by looking in the eye, by looking at how the pupils respond to light, and then we often will give somebody some colors to see, because their colors are washed out with an optic neuritis quite consistently, and the contrast diminishes, and often there's pain with eye movement. Now this is very scary when it occurs, but when it occurs, if we wait long enough, if we just say that things are going to come around and people have some confidence in us, we don't really usually need to have to treat it with anything. But normally people are scared to death, and so we often will give a high-dose corticosteroid medicine intravenously or even orally to try to decrease the inflammation quickly and bring back the vision. When the vision comes back, sometimes there are losses of vision in the visual field, so people will have pockets that they can't quite see for a while, but after a while things usually come around and people get their vision back. Maybe not perfectly, but pretty darn well. Next slide, please. Now, a different visual problem that we have to deal with is double vision. As you may be aware, there are 6 muscles that control the eyes. And these eyes muscles are controlled by the back part of the brain called the brain stem. And it's a very sensitive way so that the eyes move together and we see singly. But if we get demyelination along the tracks that control any of these muscles, the 3rd nerve muscles, the 4th nerve muscles, the 6th nerve muscles, we number them. If we damage anything along that fiber tract, the muscles move in an uncoordinated way, and the result is double vision. Double vision is very, very scary to an individual. You lose your depth perception with it. And typically when that happens, you'll be sent to a neuro-optometrist or a neuro-ophthalmologist, and they may give you prisms or they may patch your eye. But I have over the years recommended not doing that so quickly, because you need to let that brain compensate. And usually if you let it compensate, it quite often will resolve, even if the problem itself doesn't resolve. The problem may, like every other MS finding, may resolve as well, or MS symptom may resolve as well on its own or with some steroid treatment. So when people ask me, well, when if I patch an eye, I will see singly. That's one of the things we see. If you see double vision with one eye, there's something wrong with your lens rather than the muscles. But if you patch an eye and you see singly, that's good. And we want you to patch an eye with double vision if you're driving your car, because if you're not, you might not know which car is coming, because you'll see 2 cars coming at you. Or if you're reading a lot, we want you to patch an eye. Or if you're watching television or a movie, we'd like you to patch an eye. But otherwise, go about your activities of daily living without patching. And then if it doesn't come around, then we will ask to get prism glasses so that they'll bring the vision together mechanically. But that doesn't allow your brain to compensate. Your brain has amazing ways to compensate. So sometimes we'll see patients' eyes where one eye is going this way and another eye is going that way, and we say to them, how many fingers do you see? And they see it, the right number, and you wonder how that can be. And that's because the brain can compensate for a lot of things that go wrong in the body. Next slide, please. And then we talking about this very unique symptom. Well, it's not a symptom, it's a finding called an internuclear ophthalmoplegia or internuclear ophthalmoparesis. This is the one I want you to talk to your neurologist and just throw that out if you can. And INO, if you just say INO, they'll know what you're talking about, because the eyeballs themselves are connected to the back part of the brain through a very thinly myelinated but heavily myelinated fiber tract on each side of the back part of the brain. That's for your information, it's called the medial longitudinal fasciculus. Forget that, that's off the record, medial longitudinal fasciculus. But it's amazing how they control the eyes and allow them to move. But those MLFs are very susceptible to demyelination, and they can be susceptible to demyelination early in the disease. And when that happens, you get a very interesting eye movement. So if you look at the slide here, you'll see that on top, the eyes are normal. They're just staring at you. Then if we ask you to look to the left eye, I'm sorry, if you look to the right here, that's what the middle one is. You're looking to the right, and the right eye goes out and it starts to jerk in a jerky way. And the left eye, which is the one on your right side as you're viewing it, does not cross the midline. So it stays in the middle, and one eye goes out and starts jerking. And when we ask you to look the other way, the other eye will go out, and your eye that is trying to follow it won't cross the midline. That's called an internuclear ophthalmoplegia. And interestingly enough, it looks like your eyes are frozen and won't cross the midline, but if we have you just look at the finger coming into your nose, your eyes will come together. Your muscles work, it's the nerves that aren't working right. And the reason we put this up is because when we see an internuclear ophthalmoparesis or plegia on both sides, it almost is only in multiple sclerosis. It's what we call pathognomonic of multiple sclerosis. And so when we see that, we can make the diagnosis usually without little else, although we would never do that. We want to have all the testing and everything. But clinically, that's how we make the diagnosis, by looking at the finding of an internuclear ophthalmoplegia. Now, it's really hard for medical students to understand this. So I realize it's going to be hard for everybody else to understand this as well. But I wanted you to be aware of it anyway. Next slide, please. So there are many different kinds of visual problems. And there's the problem of abnormal movement of your eyes, and they can be jerky, and they can jerk around and not find the target. And when they're jerking rhythmically, we call that nystagmus. And they may be jerking on a horizontal line, or they can sometimes jerk in a vertical line. And horizontal nystagmus is caused by many, many, many things, including infections of the ear and even circling around, running around in a circle can cause nystagmus like that. But vertical nystagmus tells us there's a damage in the brainstem, the back part of the brain. It doesn't tell us what the damage is, but it tells us that there's damage in the nervous system. So when we see nystagmus, and sometimes people are just born with it, we call it congenital nystagmus, we have to find out the reason for the nystagmus. Nystagmus is a finding. It's not a symptom. It's a finding. You may feel your eyes jerk, and that would be a symptom, but mostly you don't realize it. Your eyes just are not seeing quite right. You're getting blurring or movement of the environment. We can often find a spot where we can make that nystagmus stop. We call that a null spot. The slide says it may respond to medications, but frankly, I've never found a medication that works for this. We would use a medication such as diazepam potentially to try to make it work, but it doesn't really work. Another vision problem that we all get as we get older are cataracts. And it's just almost a foregone conclusion that as you get older and older, you're going to have cataracts. That's a blurring of the lens of your eye. But when you have multiple sclerosis and you receive a lot of cortisone type medicines, such as methylprednisone, prednisone, or ACTH, that cataract forms earlier and may require an earlier surgical removal and a replacement. But it's the operations have become so smooth and simple that there's nothing to be feared over. Next slide, and I think I turn this then over to Kathy.
So who do you see about the vision problems? Well, first of all, you go to the neurologist because you want to have a definitive diagnosis. You want to rule out, is there any other medical issues going on? You want to rule out medication as a cause. And then, like Randy had said, they may refer you to a neuro-optometrist, neuro-ophthalmologist. somewhat regional. Out here, we tend to refer to neuro-optometrists. Other parts of the country, it's neuro-ophthalmologists. So the neuro part is very important because these are optometrists, ophthalmologists who really understand the unique issues going on with patients with neurological diagnoses. And they would be the ones to maybe prescribe the prism glasses if that's appropriate, and they'll have those for people to try. Also, in the world of occupational therapy, there is a specialty certification in low vision. So you may have an OT in your area who does that. And so if this becomes a persistent issue that really affects your everyday vision, they could help you evaluate low or high-tech devices, instruct you on compensatory techniques, and sometimes there are eye exercises that may help in some situations. Next slide. So the nice thing nowadays, low, high tech, there are a lot of things out there that are easily accessible, very inexpensive, and sometimes built in to equipment we already have. So one thing that sometimes can help with visual issues is increasing the font size. And anyone who has a smartphone, you can change the font size on that. On a computer, you can do the same. Usually, if you go into settings, there's usually a couple of different places you can adjust the font size. One has to do with display, but then also you can go into a setting called accessibility, which gives you even more options for people with disabilities, with impairments. You can also do a text-to-speech on some devices. So the device, your computer, your phone can talk to you and read what's in front of you. And then you can also do voice commands. I personally use voice commands all the time on my phone just for ease. Sometimes what can be helpful too is to eliminate glare. So in your environment at home, trying to eliminate glare. Be aware of mirrors and how close mirrors are to lighting to produce glare. You want to be sure you have adequate lighting also. We'll talk about balance later and how vision is a very important part of how we keep our balance. So you want to make sure you have good lighting in your room. Also, sometimes the type of lighting is very important, fluorescent versus soft, and those are things to explore. You can also, on a computer device, on a phone, increase the contrast. So you can have a darker background or lighter background, and vice versa in terms of the font. In your home, if things tend to blend in your environment, you can try brightly colored borders, such as to your light switches. Or if you have difficulty with depth perception on the steps, you can put lightly colored borders on the steps or doorways. Also, within your home, organizing your home. You don't need to worry about not being able to see your keys across the room if you know they're always going to be on the hook next to the door. You don't need to be concerned about being able to see your purse and scan for your purse in the room if you know when you come in the door, you put it on the same hook, the same doorknob. So if you become a creature of habit and organize your environment, it really saves the challenge of scanning your environment and finding things visually.
So, Kath, I just you know, I always tell people that the squeaky wheel gets the oil, and sometimes it's hard to find the right therapist to get something like vision in particular. How easy is it, in your experience, to have an occupational therapist who knows what they're doing with visual issues?
Sure. So if you go to the Occupational Therapy Association website, that's where you should be able to pull up, and that's where you can pull up the specialty certification in low vision and find one in your area.
I think that's really good advice, because sometimes neurologists don't even realize that that's available.
Correct.
We're so interested in motor problems that we lose sight of that. The neuro-ophthalmologists, I'm sure, do, and the neuro-optometrists do, but they're often in short supply as well. If you're in a city, you can find them, a big city, but if you're in a small town, you're not going to find people who are that well interested in the neurological problems of multiple sclerosis sensory issues.
And also the National MS Society very often will keep a listing too of specialists in the area.
So we also have issues with dysesthesias and paresthesias. These are abnormal sensations. And there's those big words again, dysesthesias and paresthesias. So a dysesthesia is a little bit of a painful sensation. A paresthesia is just a numbness. Those are neurologic terms that we talk about. This includes numbness and tingling, itchy, crawly sensations, burning pain, cold feet, and an MS hug. So let's think about these for a moment. Numbness and tingling can occur anywhere in your body. And because multiple sclerosis as a disease hasn't read the book, it doesn't necessarily follow any neurologic pattern. And so you could come to the neurologist with symptoms of a carpal tunnel syndrome with numbness in your hand, and that follows a pattern. But the MS numbness and tingling follows whatever it seems to want to follow, and it's very uncharacteristic of anything else. And numbness, tingling, itching, and crawling are just variations on a theme. It can be the same demyelinated area in the central nervous system that can cause numbness one day, tingling the next day, itching the third day, crawling the fourth day, and then go away and be perfectly normal the fifth day. The dysesthesia, apparent burning pain, is something that is very, very bothersome. Now, how do you treat numbness, tingling, itchy, crawly sensations? Well, you know, normally you don't. Normally you don't. The medicines are not worth the side effects to treat them unless it's just driving you up a wall. And we'll talk about the medicines in a moment, and then I'm going to ask Kathy for any clues that she might have from a rehab standpoint. But mostly I try to tell people that these sensations are not something to fear. It's something that we have to just learn to get along with and think of them as a friend, because they're not a bad prognostic indicator. Burning pain, however, is hard to ignore. And so burning pain, dysesthetic pain, that often can be lancinating and very, very irritating, we will go after with medications, but not pain medications. And I'm going to emphasize that again. Do not think that pain medications are going to help the burning dysesthesias of multiple sclerosis, because they just don't. And all you can do is create a problem with the medication over time. So we use different kind of medication. We may try some steroids at first to see if we can calm it down, but that may or may not be of value, and that's just temporary. We use medications that are used for seizures, that have been developed over the years for seizures. And there are numerous of these medications. And we try one and try to build the dose up, such as gabapentin or pregabalin, as an example. But there are many others. And we may build the dose up and try to get the painful sensation to be less severe. Burning pain is something that we do some rehab things as well. Kathy, do you have a suggestion maybe in terms of acupuncture or something of that nature?
Sure. For burning pain, you know, one of the biggest things I've heard from clients is if they are able to do some sort of aerobic exercise that produces, you know, what we sometimes call a runner's high type of thing, that's
Good idea.
Dampen it as well.
So that's taking your mind off of it a little bit. And things like acupuncture, or sometimes even a TENS unit, although a TENS unit has sometimes will irritate it more than another unit, but it's a trial and error. We try different types of things that are not, meditation is a good thing, things of that nature, to try to get your mind off the burning pain if the medications aren't perfect. Cold feet occurs sometimes because we're losing control of the venous temperature regulation in the feet. So sometimes elevating the feet or simply warming them, being careful though, if it's numb, not to get it too hot. You don't want to have a burn there. And then there's this MS hug. And I put this in because I've heard so many people that come to me say they're afraid of the MS hug. They've heard that this banding sensation across the torso, like you've been hugged across the torso, is a bad prognostic indicator, and that it's a sign of doom and gloom, and that the death is on the way. And my experience in 50 years of managing multiple sclerosis, unfortunately it's been that long, is that it's not at all. And that the MS hug, this banding sensation, this uncomfortable feeling, has no more bad prognostic indication than any other sensory symptom in multiple sclerosis. So I put that in there with the idea of just trying to reassure you that these sensory symptoms, as bothersome as they may be, do not usually portend doom and gloom.
And also back to the cold feet, what is sometimes helpful too is if you kind of learn your body as to when you tend to get cold feet and anticipate it and keep the feet warm before they even get cold. Because sometimes once they get cold, it's a little challenging to warm them up again.
Absolutely. Next slide, please. I've got another big term for everybody here, and that's Lhermitte's sign. Lhermitte was a French neurologist, and this is a sign that people have, and it's a symptom that people have as well with multiple sclerosis and sometimes without. But it's a common symptom that scares the daylights out of you when you have it, and that's when you flex your head forward, put your chin on your chest, you feel this electric sensation going down the spine. It's like you touch the wire and electricity goes down the spine. And you put your head back and it stops. And it's actually a mechanical problem that's going on there. And so consequently, if there's a damaged area, it doesn't matter what the damage is caused from. It might be a tumor, it might be a multiple sclerosis. Depending on the individual circumstance, it could be trauma. If it's damaged in the neck region and the neck gets stretched, that short circuits and sends that electrical sensation down. That's usually a temporary thing. It's usually not something that continues on an ongoing basis with multiple sclerosis. We hear the symptom, we want to make sure that we have the right diagnosis, but given that the person has MS, we may want to treat it with some of those electrical seizure type medicines that I talked about before, gabapentin, pregabalin, some of those medicines like that. Again, it can be very frightening, usually not a bad prognostic indicator. Trigeminal neuralgia, on the other hand, can be severely painful. It's an electric sensation in the face. And the trigeminal nerve is the nerve that comes out from the back of the brain, and it has three divisions. One goes to the forehead, one goes to the eye area, and one goes below to your face down here. And that is a common problem, trigeminal neuralgia, in the world. In people who, as they age, they get this severe lancinating pain in the face because of an irritation of that nerve. But when we see it in a young person, when we see trigeminal neuralgia, or another name for it is tic douloureux, when we see that in somebody who is young, we start to think, could this person have could this person have multiple sclerosis? Now, trigeminal neuralgia, you can't live with very well. It's too painful. It hurts too much. So we may try to get rid of it with a course of steroids, and if that takes care of it, fine, but often it doesn't take care of it. And then we have to use medicines, again, the same kinds of medicines that we use for seizures, but the one that's used primarily is a medicine called carbamazepine. And that usually works. But if it doesn't work, there are surgical procedures to try to take this down. And we can freeze it actually with a laser type of procedure to take the pain away, and leaves a numb patch. And so that's not the greatest thing in the world, but it's not the worst thing in the world either. This is a symptom that we need to treat aggressively when we see it, because if you've seen anybody with trigeminal neuralgia, you don't want to let that go. Interestingly enough, trigeminal neuralgia, as seen in the older population, has a trigger area. If you're shaving or you touch your face or you're eating, you feel that sensation. In multiple sclerosis, it may or may not have that trigger area that lets us know for sure that this is what we're dealing with. Do you see that in rehab at all, Kathy?
Thankfully, not as much, no.
But you see the Lhermitte's, I'm sure.
Yes, yes. Mm-hmm.
Next slide, please. So another symptom that causes a sensory problem is a motor symptom, and that's a spasm, usually in the legs, but sometimes in the arms. We'll see the arm spasm as well, but usually it's a spasm, and it may be a flexor spasm where the knee bends and the leg moves in, or it may be an extensor spasm where the leg straightens out. And this is caused by short circuiting in the spinal cord, usually with multiple sclerosis. Can be in the brain, but usually in the spinal cord. and that can cause pain, a painful spasm. So when we see that, the first thing that I recommend is therapy, but I'll pass it off to Kath in a moment for that. But that's usually the first thing we want to have is some therapy. But then we will try some medication. And there are lots of medications for spasticity and for spasms that work very effectively. Baclofen, tizanidine, there are many that will work very effectively. And then there's some of the Parkinson's medicines that work effectively as well, dopaminergic agonists that help with this painful spasms as well. And then when that doesn't, if for some reason that doesn't work, and then we're going to talk about therapy in a second here, sometimes Botox can be of value in there. And if that doesn't work, we can put in a pump into the spinal canal and put baclofen into the spinal canal, and that will work to decrease these painful spasms. One of the things that we have to look at when we see painful spasms is we want to look at the calcium in the body and the magnesium in the body and the metabolism, and we want to make sure there's no infection going on that's creating the aura that allow this to occur. So there's some medical things that we look at there, but my first referral is to the physical therapist.
So with spasms, to simplify, spasticity, it's basically a hypersensitivity of the muscle to being moved. So the more flexible the muscle is, in theory, the quieter the spasticity should be. The more spastic a muscle is, sometimes the tighter the muscle becomes. So you get this vicious cycle of spasticity, tightness, more sensitivity, more spasticity, etc. So with therapy, we try to break into that cycle. And one intervention we do is teach stretching exercises. We try not to burn you with every possible stretch, but we try to see if a limb, for example, if the leg becomes a 2x4 because it's so spastic, we try to see, is there a particular muscle in that leg that tends to trigger the whole leg to spasm out? So, for example, if someone is in a wheelchair, we look at the position of the foot. If the foot is has a clonus, a shaking, and maybe spasms off the foot plate, does that send the whole leg out? Or if we can position someone in the wheelchair so at the hip they're a little more flexed, does that calm the whole leg so it doesn't become a 2x4? So we look for, is there a specific muscle that's a trigger? And, you know, again, we teach stretching exercises. Maybe we'll ask, hey, there's so much spasticity in this muscle. We'll send them back to the doctor, say, can you Botox this muscle? It seems to be the culprit for sending off the whole limb. And we look at positioning. So if we lock, for example, the ankle into a 90-degree angle when someone's walking, when someone's sitting in the wheelchair, then that ankle can't be stretched to trigger a spasm that might set off the whole leg. So positioning and stretching. Also weight bearing. If someone's unable to stand on their own, sometimes we'll explore the idea of a standing table. So that whole body weight of coming down through the joints, through the muscle, that also sometimes can help relax the spasticity. We also have an electrical stim bike. If someone's not physically able to ride a bike themselves, we may hook them up to an electrical stim bike because that's been shown to calm down the spasticity as well as providing aerobic exercise. So there are different tools that we can explore to figure out for one particular person what tends to work best for them.
Let me just throw in here for a second that sometimes those painful spasms occur at night when you're in the bed, and all of a sudden that leg starts to spasm. And if you can get out of the bed, if you're able to do that and walk it off, that will break the cycle as well. A little trick of sorts, if you can do that.
And also, you know, back to positioning again, if someone isn't as mobile, then we can explore, do we need to get braces for the ankle to lock the ankles into a 90-degree angle so they don't spasm out? Do we need to put something in between the legs so they don't scissor together and cause problems? So again, exploring what seems to trigger the spasticity and how can we get you out of those positions to calm it down. Next slide, yeah. So managing pain, one thing we've learned about pain over the years is that the source of pain is only part of that pain that we're perceiving. So different ways. So this is by no means suggesting that pain is in your head. Sometimes when I start explaining this, people are saying, oh, so you think it's all in my head? No, not at all. But what we have found over the years is some people are able to manipulate their perception of pain. So some of the things we explore is your experience with pain. Does it trigger certain things? So for example, if I'm going on a run and I've had a really bad day and I'm trying to go for a run and just open my mind, clear my mind, and I fall and I sprain my ankle, that ankle may hurt quite a bit because I'm in such a bad mood to begin with. So that straining that ankle is just triggering an emotion in me that just makes me angry and makes that pain way worse than maybe it needs to be. If you're experiencing the MS hug or some sort of discomfort or spasticity that you experience off and on, does that trigger that idea of, oh, I'm so sick of this MS? And does that make that pain just come to the forefront of your mind and that's all you can focus on? And can you learn to manipulate that trigger that the pain may give you? And does that alter your perception of pain? So instead of being a 10 out of 10, can you bring it down to much less, more bearable? Pain, pain can be helpful. For example, if I was to fall and twist my ankle, if any of us do that, pain can be helpful. It's a protective response. Having pain in that ankle tells me, well, it's hurt, take it easy on this ankle, it needs to heal. But sometimes pain is not giving us useful information. So when you have nerve pain like trigeminal neuralgia, MS hug, or any sort of other nerve pain, that's not giving you helpful information. So if you educate your brain and make it understand that pain message is not useful, it's not teaching me anything, can I learn to ignore it because I don't have to be protective of that part? It's just that MS thing happening again. And can you learn to compartmentalize at all? Some of the other things that make people experience pain that's much larger than maybe it needs to be is a social response. So for example, if you're in an environment with your family, or you were raised in a family where you're just taught to walk it off, and that you can't take the time to accept the pain and deal with it, sometimes that triggers also negative emotions that may make it difficult for you to control your perception of pain. And can you easily communicate with pain, about the pain? So do you have a good friend that you can say, hey, instead of going to the mall, do you mind if we just hang out at a restaurant and just talk and relax because I'm having a bad pain day? Otherwise, does experience pain make you feel guilty, but you're not able to do what you're planning to do with family and friends? So again, not at all suggesting that it's all in your head. Everyone pain is different. Every pain issue is different. But over the years, people have learned that sometimes they can manipulate their perception of pain, perhaps bringing it from a 10 out of 10 to more of a 5 out of 10 over time.
I'd like to just reinforce what Kathy is saying here a little bit and give you the benefit of 50 years of watching pain evolve as a management problem and as an issue. When I was a young pup 50 years ago, literally, it's my 50th anniversary of being a physician. When I was a young pup, we had pain clinics, and these pain clinics were very effective, but they were run by psychiatrists and run by psychologists, and they were very effective, and we didn't utilize a lot of pain medication for chronic painful problems. Obviously for orthopedic problems, broken leg, things of that, and post-surgical problems, but for chronic problems, we didn't utilize any opiates and things of that nature. And then along the way, something happened, and everybody got concerned about pain, and pain became an issue, and the pain got moved out of the psychiatry office. And these people were not crazy. That's not why they went to the psychiatrist. The psychiatrist just did behavioral types of therapies, and the psychologist. It got moved from them to the anesthesiologists and to the physiatrists who were pain specialists. And many of them got involved with managing chronic pain, and neurologists. I don't want to make them blameless either. And we started being told that we should utilize medication because pain was so bad. And we did. And now we're coming back to the realization that we have to have an alternative way of managing chronic pain. And so we do it with rehab procedures. We do it with psychological ways of managing pain, and understanding that we want to find the source of the pain. We want to find the trigger of it and try to get it settled down. And we want to have a response to it that's appropriate, that isn't going to be worse in the long run for the person. So I can't emphasize enough, pain clinics don't do very well with MS pain. If you find a pain clinic doctor who can deal with MS pain well, I love that person, whoever it happens to be. But I get very concerned that the fast way of treating it is to take a medication, and it's not a anti-seizure type medication, it's a opiate type medication, and that is just not the way to work over the long haul.
And I think we found patients who also find meditation helpful, different ways of biofeedback for relaxation. You know, I have so many patients who say the pain's worse at night. It's like, well, yes, because everything else is quiet at night. And so that's all you're experiencing. So, you know, that's where maybe meditation can come in, something like that, that can help quiet it, even though in those quiet times at night. Next slide. Somatosensation. So we use 3 sensory inputs to keep our balance, to figure out where we are in space. And one of them is somatosensation. What that is your ability to feel the floor through your feet, to know where your limbs are in space. And sometimes we get challenged by that with our environment. So it's always easiest to stand on a firm floor with bare feet, so you can really get a reference point. I'm on a stable ground, I'm okay. If you're on a moving terrain like planes, ships, docks, amusement park rides, where the surface you're standing on is moving, that can throw off your ability to use any sort of somatosensation to keep you balanced. Uneven terrain, going over grass, sand, broken pavement, where your ankles are constantly having to respond to lateral shifts or forward and back shifts, that sort of thing, that can be very challenging as well. Sand is particularly challenging because with sand, you find the earth moving from underneath your feet. So I always tell people, if they're working on sand, if they're walking on sand, to the water, hopefully with low tide, tides going out, so it tends to be a lot firmer. And then compliance surfaces, thick, squishy rugs, soft shoes, that also can take away your ability to get a reference point from the ground you're standing on. Next slide. So compensatory techniques. So to just sidetrack a few minutes, people who have numbness issues, if they come in saying, I really can't feel my feet that well, what I remind them is that people with fake legs, with prosthetic feet, are able to learn to feel the floor through that prosthetic leg. So I always challenge people, I want you to take a few steps with me right next to you with your eyes closed, so you can really listen to whatever information you are getting from your legs. Even though it's not normal, you know your legs are there, you know they're hitting the ground, and learn to feel that and use that information. Some other things I suggest to people is to avoid shoes with soft cushions. You know, some of my patients will tell me, oh, I'm more balanced, I walk better when I'm barefoot. And that's because they can interface with the floor and really get a good reference point from the floor. Avoid shoes that don't stay secure on your feet. So if you have sandals and such, be sure you have a strap that goes around the back, so the shoe that you're walking with isn't sloppy underneath your feet and throwing you off in that way. Choice of rugs or terrain, the firmer the better. Assistive devices. So assistive devices can do 2 things for you. One is it can just mechanically help you hold yourself balanced. If you start to trip, you got something to catch yourself with. But another thing an assistive device can do is give you another connection to the floor. So some patients this way will tell me, oh, I just need a simple walking stick. And what that does is, if you can't feel your feet touching the floor really well you can feel the walking stick touching the floor. So that gives you just another connection to the ground. Orthotics, braces. So if you don't know where your ankle is in space, if you put it in a brace, you know it's behaving, right? You know your toes aren't dragging and it's doing what it needs to do. It's not going to twist when it lands. So that's where braces come in handy for sensory issues. Next slide. So different assistive devices. You get the front wheel walker. You get a straight cane. There's also a quad cane that has 4 legs on the bottom. That's a little more stable. A lot of people like using the 4-wheeled walker. For one thing, it's got a seat that comes with it, so you always have a chair with you if you get tired. And then on the far right are walking sticks that some people like because aesthetically it looks more athletic. And sometimes that's all they need is just a little something to keep their balance. Next slide. So braces. On the left, we have low-tech braces. So on the top there, you have a plastic custom molded AFO. That one in particular has an ankle joint in it. So we can give you as much movement or as little movement as you can control in the ankle. Even if you have a solid plastic AFO, we can keep it a little more flexible so it doesn't feel so rigid just by having the orthotist use less or thinner plastic. On the bottom is a toe-off brace, and it's configured uniquely. So you can see the upright strut that comes from your calf, instead of attaching to the back of the heel like the top plastic one does, it attaches more mid-foot. So when you step on that heel, it flexes a little, so you're rolling over the foot almost like a normal walking pattern. And on the right-hand side is a hip flexion assist device. Not covered by insurance, about $300, and actually was designed for people with MS. So it's got that sturdy belt, and all this can be worn underneath your clothes. You don't have to make the fashion statement here. It's got a sturdy belt, and then it's got a belt on the bottom that hooks onto the shoes or your sneakers. And then those are basically bungee cords that run up and down your leg. So if this person here steps forward with their left stronger leg, then those bungee cords are going to become taut. So when they go to move that right leg forward, it's like spring-loaded. It can really help lift the leg. Next slide, please. So then we have high tech. On the left-hand side is the BioNets, the L300 Go. And that cuff you see around the calf has electrodes embedded in it. And those electrodes stimulate that muscle that lifts your toes up with every step. And in that box that you see on that cuff is a sensor. So it senses what the angle is of that calf. And it will sense, oh, she's about to lift her leg up because her calf is angled. I've got to stimulate that nerve so she doesn't drag her toes. And then also you see there's a thigh cuff on this, which a lot of people don't get. But you do have the option of getting a thigh cuff to stimulate either the front or the back of the thigh. So this BioNets device can be used by some people in place of the brace. It is thousands of dollars more, but some private insurances pay for it, and actually in the state of California, some of the Medi-Cal sign-over HMOs will pay for it as well. On the right hand, actually at the $200, but it can be used for neuromuscular re-education. So someone who's really walking with difficulty or not walking at all, this can be programmed to fully control their ability to walk or just provide some support. So if someone's able to initiate a step, then it can be programmed to take over and complete the step for you. So we use it in the clinic for motor re-education, and it can be helpful for some people. Next slide. So balance-based torso weighting vest is created by a company called Motion Therapeutics. And it's a vest that you wear, and it has weights on it, very small weights, 1/4 pound, 1/2 pound. You know, probably the most I've seen on one vest is maybe 2, maybe 3 pounds that are strategically situated. The purpose of this brace, I always say, is it's magic. If you look on the website, there are some videos that are very wow moments of how this vest has improved someone's ataxia, their balance. We have some patients who don't respond at all to it, and some patients who have a response. But you can be evaluated for it, and what it does is it provides just a little more proprioception to the trunk. And we've had patients who say, you know, now I really feel like where my posture is, how to control my posture, where I am in space. Some insurances do pay for it, especially if you can also say that you have back pain, because they insurance understands the concept of a vest for back pain issues. Next slide. So how to choose what assistive device, what orthotic, what do you need? So the main thing is, to promote my profession, is you really should be evaluated by a physical therapist to really kind of tease out what the issues are and therefore what equipment may help with that issue. Also, you really want to trial the equipment because this stuff can be expensive. If you want to pay for by insurance, you sometimes need some good objective information that the therapist can evaluate you for to write up a good letter to get things covered. And basically, you know, what's the best thing for you? Kind of what makes you walk most normally. So when you walk most normally, then what we can presume is that you're going to be walking with less energy expenditure, less fatigue, also less spasticity. So spasticity is really wearing your emotions on your sleeve. So when something's really difficult, usually it kicks up the spasticity even more. If something's a lot easier, such as using a walker to walk with or a brace, sometimes that can relax the spasticity and make the walking less laborious, more smooth and rhythmical. And of course, when you're walking more normal, then your fall risk tends to be less as well. Back to you, Randy.
So we're going to talk a little bit about a very complicated topic, and I'm going to try to make it as simple as it can be, but it's really complicated. And it has a lot to do with sensation and how your body uses sensation to keep yourself upright and functioning, or even sitting and functioning. Balance is very complicated. It involves the back part of the brain, which we call the cerebellum, the balance part of the brain, that keeps us from shaking with tremor and keeps us from falling over. It involves the ears, where, as you all know, the inner ear has balance organs that are associated with keeping our head upright, knowing where our head is in space. It involves the spinal cord to take that impulses down to your legs, where your feet feel the ground, as Kathy so eloquently said. You feel the ground, and that input goes up the spinal cord into the brain and then gets computerized and keeps your balance. So anything that can go wrong sensory-wise, in the ear, in the brain, in your feet, for any reason, whether it's multiple sclerosis or whether it's infection in the ear or whether it's a neuropathy in the legs from diabetes or other diseases, will throw your balance off. When it gets thrown off, the neurologist and also the physical therapist has to figure out why it's been thrown off. And so we have some terms. Sometimes the world is spinning and you feel that spinning. And I always say that if you haven't experienced vertigo, which I think everybody has, I can make you experience it. But I think every 4-year-old has experienced vertigo, because every 4-year-old has spun around, spun around, spun around, spun around, and then stopped. And when they stop, the world keeps moving to them, or they're moving and the world has stopped. So that's called vertigo, that spinning sensation. It can be a spinning sensation of the world spinning, or it could be a spinning sensation that you're spinning. And that can come from your ears, or it can come from your central nervous system. That is a particular symptom that we have a particular workup to look at to find out why that's happening. But more commonly than vertigo is an unsteady dizziness. I put lightheadedness and dizziness into the same basket often. It's a funny feeling. You can't necessarily put your finger on it, or you just may feel a little bit off balance. That can occur because you have multiple sclerosis and it's giving you that symptom, but it could occur because you have low blood pressure. It can occur because you have a low blood glucose from diabetic problem or a medication problem. It can occur from medication. It can occur from not sleeping well. It can occur from sitting in the car and getting motion sickness, and it can occur from many different ways. When we see vertigo, and that's a neurologic workup that we're doing, including the ears. It's neurologic workup. When we see dizziness, it becomes more than that. It becomes a medical workup to try to figure out why that person has that particular symptom. Next slide, please. So when we see the vertigo, that spinning sensation, a common problem that isn't MS, that many, many people have, is called benign positional vertigo. Benign positional vertigo. This is occurring because of calcifications that are occurring in the inner ear. That inner ear has hair cells, hairs that are going like this and keeping your balance. And there are 3 canals that have these hairs going like this to keep your balance. And they tell, in a computerized fashion, they tell your brain where your head is in space. But if one of those canals isn't working right, then you get false information. And that's what occurs when you spin around, spin around, spin around and stop. You get false information going in, and it tells your head is somewhere where your body isn't. That calcification is pretty benign, but it can be very, very disabling if it's happening frequently. So there are some physical therapy type maneuvers called Epley maneuvers that we teach people to do to make that subside. So we want to check that out. We want to see whether that's the issue, because that's easily treated. We have some medications that we can use. Meclizine being one of those medications, not the best. Dramamine sometimes, Valium, diazepam we can use. Not the best, but will help. But in this kind of situation, if it's constant and continuous and I can't get it to just go away by teaching the person the Epley maneuver, I want the physical therapist to be involved heavily, because they can really manage this well if they're trained in that area. But sometimes it's not so simple as that. Back a slide, please. Sometimes it's because there is demyelination that's occurring in the back part of the brain stem. And when we see that internuclear ophthalmoplegia often that we were talking about before, but we may just see the nystagmus. It may be vertical nystagmus up and down. It may be horizontal nystagmus this way. And then we have to treat that as a very important MS attack. We don't like to see that, because that brainstem has our vital functions right there. So when we have a brainstem attack, we want to be aggressive with our management strategies with steroids and make sure that the appropriate disease-modifying treatment is being used. But I think everybody, when they get vertigo, says, oh, it's the inner ear. And when you go to your family doctor, I will venture 9 times out of 10, they will say, oh, it's the inner ear, it's labyrinthitis. And they will treat you with some medication or something of that effect. It often isn't labyrinthitis, but it can be. And then we have to look at metabolism. We look at different parts of the blood work to make sure everything is functioning right. So the workup is dependent on the circumstance. This sensory organization that Kathy's going to talk about here is very complex. It's not simple. And it's amazing how well it works most of the time.
So back to the medication issue, there are some medications that can help suppress some of these symptoms. If you are being sent to a physical therapist for dizziness, for balance issues, be sure the physical therapist knows that you're on some medications to suppress some of these symptoms, because there may be times where we suggest that you not come to therapy with those medications on board, because we want to know, we want the brain to learn and to eliminate the symptoms without the need for medication. So sensory organization, we use 3 sensory inputs to keep our balance. We use our vision quite a bit, and we get a reference point. So, you know, again, if you're on a boat and you see your horizon moving, that can really throw you off. Or if you're in a car and the car next to you moves, and you're like, oh, that wasn't me. But that's because you lost your visual reference point. So if someone is challenged, one of the things I may suggest to them is, if you're in a crowd and having that crowd move by you is really throwing off your balance, what you want to do is focus on something straight ahead that's not moving. A clock on the wall, something, painting on the wall, and just tell whoever you're with, I'm not going to turn my head and talk to you. I need to look straight ahead to get a visual reference point. That's when we tell patients, when you get up at night or when you're walking anywhere, be sure you have light enough on that you can use your visual reference point to help keep your balance. We already talked about somatosensation, and then Randy was talking about the inner ear. So next slide. So this machine is the Neurocom, which some departments have, and there are other simpler machines out there as well. There are other testing that we can do if we don't have a machine. And then the point of these tests is to figure out what sensory input are you not using well. The Neurocom is nice because it'll spit out objective data as to whether you're having trouble using somatosensation, vision, or your inner ear. And it'll compare you to people of your own age groups so statistically we can see what level of impairment you're having. And just like we can get certain exercises strong, certain muscles stronger with exercise, if we know which sensory input you're having challenge with, we can target exercises to help improve. And we can see your statistics greatly improve on the Neurocom or other testing. And that was it for that slide.
So then there are some unusual sensory symptoms. Hearing loss, vision loss, very common. Almost everybody in MS has some visual issues at some time or another. Hearing, very rare, very rare. And when it occurs, it almost always comes back. So that is an unusual sensory symptom as far as I'm concerned. Painful intercourse, dyspareunia. I just threw that in because sexual issues in multiple sclerosis are very common. And what's important is to talk about them. And sometimes there's painful intercourse in them because of vaginal dryness or the dysesthesias, those painful sensations that occur. Sometimes it's for a mechanical reason, it needs to be worked up and checked out. And sometimes there's painful urination, dysuria, pain because there's a bladder infection or because something is wrong in the bladder tract. These require medical workups more than neurologic workups, and we can't ignore them. And so I wanted to just bring those points home. So we have some key takeaways, and we're running out of time. I never thought we could talk so long about such sensory symptoms, but I think we have. But you know, I feel sort of strange because we've used a lot of big terms, and I want you to really make your neurologist think you know something when you go see him or her. We talked about optic neuritis and retrobulbar neuritis. That is inflammation of that optic nerve. We talked about that internuclear ophthalmoplegia where the eyes don't move in a coordinated fashion, INO, because of the brainstem problem that can cause problems with your balance and coordination. We talked about the Uthoff phenomena, which is that the heat and stress and fatigue making the symptoms come on. We talked about optic neuritis and retrobulbar neuritis, inflammation of the optic nerve and the retro and the back of the nerve as well. We talked about diplopia or double vision. We talked about nystagmus, jerky eyes. We've talked about a lot of very interesting but difficult terms. Lermit's sign, the electrical sensation going down the spine. Trick-Dolaru, trigeminal neuralgia, the facial pain. We've talked about things that you'll never talk in common conversation about. But I hope that you've gotten something out of that and understand that MS is a very interesting disease that we've made such tremendous progress on, and that these symptoms are not symptoms of doom or gloom. They're symptoms that we can manage in some way, shape, or form.
So the takeaway too is, you know, that's what a neurologist is there for. That's what a physical therapist is there for, to complain. Talk about these symptoms, talk about what's going on, because you don't know what tricks of the trade are out there, what could be done about it. It's not something necessarily, oh, it's just the MS. You don't necessarily have to settle for all these things.
So there's a book that you're looking at that's in its 6th edition, Managing the Symptoms of Multiple Sclerosis, and that's just because there are so many symptoms that the book was written over many, many years. Different ones. The MS Society has lots of information, and there are other places as well. So now, Krista, do we have time for questions or not? I don't know. No, you're not talking. You're being muted.
I'd like to try to squeeze a couple in if you guys don't mind. We might go a couple.
I have all night. I don't know how much time you have, but it's only 6:15. You know, Kathy and I are on 6:15 time. You know.
Yep, exactly. So we had a lot of great questions. First, as a reminder, I just wanted to remind everyone on the webinar tonight that after the webinar concludes, you will see a survey pop up on your screen. We ask that you complete that so we can continue to improve our programs. But yeah, first, let's address a couple of these questions. If we didn't get to your question tonight, know that you can still submit that on our website. The first question that I saw that stood out to me is, I'll probably direct this towards Randy first. Is it safe to push through the symptoms, or do I need to rest when I get sensory symptoms?
So I always advise patients that people who have MS are not fragile. They're not going to break if they overdo here and there. The idea is not to push the envelope to the point of breaking, but they're not fragile. And so with sensory symptoms, yeah, I think it's very easy to push, not easy necessarily, it's very advisable to push through it if you can. But just recognize that, have a grain of common sense involved with this. You're not going to break because you're fatigued, but we don't want you to go to the point of fatigue that you can't stand it anymore. And so sensory symptoms, same thing. Do what you can, push through if you can, but use a grain of common sense.
Nice. Kathy, this one's more for you. Do I have to wait until I have pain to start PT, or can I request it as a preventative and/or to develop endurance?
So what I always recommend to actually my clients with more chronic conditions is that just like you go see your neurologist on a yearly basis, on a routine basis, you should also go see your physical therapist. So you don't wait for a crisis. And just for a tune-up or to kind of reassess, oh, how am I compared to last year? Any other ideas you have for me? That sort of thing. So no, you don't have to wait, and you shouldn't wait.
I brought my consultant in just because I don't know anybody that doesn't like to see the brains behind the outfit.
Randy, I have another one for you and your consultant there. Does a progression of sensory symptoms indicate new lesions?
Well, you know, sensory symptoms can come and go and get bad or worse depending on how you're feeling. So often when we see a progression of sensory symptoms, it's because somebody is stressed out, or because they're weak, or because they're fatigued, or because they have a bladder infection, or because something is going on. But it can also mean progression as well. And so that when a symptom is progressing, that's the time to get on the phone, talk to your provider, get seen if necessary, make sure that everything is okay. We may need to do an MRI to double check to make sure that our management strategies are online with it. So communication, Kathy said that, I'll say it too, it's a really important thing to do.
Awesome, thank you. Okay, one last one. Let's see. Can acupuncture help with sensory issues? Someone in my support group mentioned it.
Acupuncture can help for an individual who is into that type of thing. I've seen it help, and I've seen it not help. So, but what I like about acupuncture is that the risk is worth the benefit. It's not a lot of risk with it. The cost may be depending on the circumstances and whether it's covered or not, but it's a treatment that I advocate for those kinds of things if we can't get a handle on it in another way.
Yeah. Great, thank you for all that feedback. And again, if we didn't get to your question tonight, make sure to go to the Can Do MS website and check out our Q&A page where we can answer any of those questions we didn't get to this evening. The webinar may be over, but we hope that you'll stay connected. Please follow us on social media for the latest programs, resources, and MS news. You can also register for our monthly e-news by visiting our website, cando-ms.org. I would also like to highlight some resources available from the National MS Society. They have a variety of brochures and video segments. I know that we did share one on the resources page tonight, so please feel free to look that up later. We'll share that with you tomorrow in the follow-up email. You can also contact the MS Navigator at 1-800-344-4867. Our 2020 Jumpstart programs are now all virtual. These personalized Jumpstarts include 2 learning segments, 3 self-guided courses, and a live online program, which includes group discussions, Q&A, and support sessions with MS experts. Register today and attend our most popular programs safely from your home. The opportunity for online learning and connection is more important than ever in the MS community. Can Do On Demand offers advice from MS experts as they present topics on everything from cognition to exercise. Access these topics and learn at your own convenience. So the next presentation in our webinar series will be on Tuesday, August 11th, and will be on the topic of relationships and intimacy. We'll meet here again, same time, same place, 8 p.m. Eastern time. We hope to see you all there. And of course, thank you to our sponsors for making programs like this possible. And thank you to both Randy and Kathy for joining us tonight and leading the presentation. And most of all, thank you so much to all of our participants for showing up tonight and being here. We really appreciate you guys coming to join us this evening. For those participating live tonight, you'll see a survey pop up on your screen in just a minute here. Please take a moment to complete this survey, share your input. It really helps us to continue to improve our webinar series. Thank you again for joining us and have a wonderful evening. We'll see you next time.
Bye.